with the PowerPoint. And if you have any questions, just type them in the chat box or either ask me as we go along. I don't always check the chat box until the end. So if you have any questions, you might want to just ask me as we go along, because that's fine. Okay, I'm going to start recording. Okay, can you see my screen?
Yes.
Okay,
yeah.
And you can hear me. Okay, all right. Okay, so away we go. The first section that we're going to talk about is glomerulonephritis. I'm not going to review the objectives with you. You can read those for yourself. Basically, glomerulonephritis can be a disease that is primarily confined to the kidneys, caused by something that is going on in the kidneys, or it can be due to a secondary and systemic disease. Something that would be primary might be the acute glomerulonephritis, which we're going to talk about in a little bit, nephrotic syndrome, maybe primary glomerular disease, and maybe some type of kidney abnormality that is presenting itself. And then the secondary is usually due to some type of a systemic disease like lupus, which is a disease that affects the autoimmune system, as well as Goodpasture syndrome, because that attacks and destroys lung tissue as well as kidney tissue. So there's a whole list of secondary diseases that can affect the kidneys by secondary intent. And I put this little guy on here so that this could kind of help as a visual for you to help you remember what's actually going on. Because when you think about the kidneys, hypertension and, spilling protein and all of those things go along with it. So when you think about all of those things, the antigen and the antibody reactions that we have going on, think about how it affects the glomerular filtration rate. Well, it decreases it, and we also have inflammation. So we're going to have the blood pressure is going to go up. That's going to cause us to have a headache. We may have some facial or periorbital edema because we're hanging on to fluid and not getting rid of it like we should. We may have a low-grade fever because of the inflammation. We're, of course, going to have weight gain because we are hanging on to fluid. So that may be part of the problem. Somebody is not on mute. Can you mute yourself? Okay, thank you. You're also going to be finding protein in the urine, blood in the urine, and of course the urine output is going to drop as well because we don't have the filtration going on that we should. And basically, whenever you have an inflammation of the kidneys, that is of the glomerular capsule, and it can lead to, of course, a decreased blood flow, a retention of the waste products, which you would see with the edema, as well as uremia. I don't know if you've ever had the opportunity to see anybody with the uremic frost or not, but critically ill patients occasionally develop this, and it is just a little fine white crystal type dust almost that forms on their body, and it's as a result of the toxins that is not filtered out in the kidneys. And then, of course, the reason that we have hematuria with this particular condition is that the glomeruli is damaged from whatever process was going on, and it causes the red blood cells, or allows them to actually leak out into the urine. Now, whenever you have the decreased renal blood flow, the renin-angiotensin-aldosterone system is activated, because this is going to cause your fluid retention and mild hypertension, which we've already talked a little bit about. And then the inflammatory process in the kidneys begin to excrete the needed protein, which causes the proteinuria that we see. And then in turn, this can actually lead to a stroke due to the loss of proteins that keeps the blood from clotting. So it's kind of like a domino effect. Acute glomerulonephritis is an inflammation of the glomeruli, which causes the kidneys to malfunction. We predominantly see it in children from 2 to 12 years of age, and the incubation period is around 10 days. Basically, what happens in this condition, the crescent-shaped cells in the Bowman's capsule become damaged. The patient becomes very ill. They have fluid retention, hypertension, decreased urine output, electrolytes become imbalanced, and then they develop the uremic syndrome. And a lot of times, these patients have had some type of a previous infection or some type of a systemic disease. Strep is one of your main culprits of this, and this can lead to end-stage renal disease, but the percentage is very small, and we'll talk about that a little bit later. It's just like I said, the post-streptococcal glomerulonephritis occurs sometimes because of the beta hemolytic strep that attacks the kidneys. These antibodies are produced by the kids whenever they have strep throat, and then it is deposited in the glomeruli of the kidneys. And most of the time, these kids have a full recovery. There's only about 10% of them that actually progress to end-stage renal failure and that have to be placed on dialysis eventually. So what are some of the things that we want to assess these patients for whenever we are doing our history? We want to check them for any type of infections that they may have recently had, skin, respiratory, any type of body piercings, any lesions that they have they traveled anywhere that they could have picked up anything. Parasites may also be a contributing factor. Have they had any recent surgeries that may have introduced the bacteria into their system? Do they have any type of a systemic disease that may alter the immune system as well? How long has their symptoms been going on? What are their symptoms? We'll talk a little bit about the clinical manifestations again in a couple of minutes, but all of these are things that you want to consider whenever you're trying to collect your history on these patients, because sometimes it's not clearly evident, and a lot of times they may have forgotten that they had strep throat 2 or 3 weeks ago. So sometimes we have to mention things like that, and then it's like, oh, yeah, I did, because they don't necessarily make that connection. So what are some of the clinical manifestations? Well, we've already talked about some of the manifestations as far as the proteinuria, hematuria, hypertension, weight gain because of the fluid retention. We may have crackles in the lungs because fluid is shifting to the lungs rather than being filtered out through the kidneys if they were normal and functioning as they should. You also may have a third heart sound that occurs in some patients, and it's called a gallop. And if their condition is pretty significant, you're going to see neck vein distension as well. So that's one of the things that you want to observe for. And I don't know if y'all remember this or not, but the third heart sound gallop in adults is indicative of heart failure. So if you hear that third sound, which sounds like a gallop, it may be that the person is in heart failure, or they are very close to being in full-blown heart failure. Now, this sound is normal in young people and very well-trained athletes, but in your older population, it is not. And basically what causes this is the sudden decrease in the blood flow into the left ventricle from the left atrium caused by this fluid retention. They may also complain of fatigue. They're just very, very tired. They have malaise all the time. Nausea, vomiting, anorexia, those are very common clinical manifestations as well, because they're retaining toxins and they're holding on to toxins. So that's going to make them not feel well, and it's going to make them nauseated, and they're not going to have very much of an appetite. A change in the urine, it may be, the amount may be decreased significantly, or they may be completely anuric. They may not have any urine output at all. Or if they do have urine output, it may be a very small amount. It may be very dark and tea-colored. So has their voiding pattern changed? Are they voiding a lot less now than they were a week ago? Has there been any change in the clarity of their urine or in the odor of their urine? We also want to assess these patients for any type of renal failure that is going on. We want to look at their electrolytes, what's going on with the electrolytes, particularly the potassium and the sodium. And we'll talk a little bit about lab work too in just a second. So some of our diagnostic tests include the urinalysis, which we would be looking for protein and red blood cells, which we've already talked about. We've also would be looking for an albumin level, because chances are their albumin level is going to be low because protein is leaking out into the urine, like we mentioned before. 24-hour urine collection may be done to estimate what their glomerular filtration rate actually is, in effort to try to determine how far they are. And typically it should be greater than 90 milliliters per minute in the average adult. We also want to look at their serum creatinine and BUN. And we'll talk a little bit more about those too in just a second. Cultures of the throat, the skin, and the blood, especially if they have any type of superimposed infections. We may want to look for antibody screening to see if they have any unusual antibodies that might be causing a problem. And then our most definitive diagnosis would probably be the kidney biopsy if all else fails and we can't determine what's actually going on with them. I do want to talk a little bit about some of the lab values. Your BUN, which measures the effectiveness of the kidneys to excrete the urea nitrogen, which is a byproduct of breakdown from the liver. Usually it's going to be increased if we have any liver issues or kidney disease going on. It can also be increased with dehydration and any type of decreased kidney perfusion, or maybe the person's on a high protein diet. It may also be elevated. Infections, stress, steroids, and I think we talked the other day about GI bleeding too. It can be elevated in that particular condition, and that's why, because it measures the effectiveness of the kidneys to excrete those toxins. Your creatinine is 0.6 to 1.2. That's the norm, but just remember those are all relative depending on the facility you're in. This particular lab value is produced when the muscle and proteins are broken down. The protein breakdown is constant and is a very good indicator of the kidney function. It is slightly higher in men due to them having more muscle mass. So if you look at a guy's lab work and his is a little bit higher than what the norm is, then that's not anything to be that alarmed about. It's just something that we want to continue to monitor. So, and And then if we're looking at the BUN and creatinine ratio, that's another test that we use to evaluate the kidney function. And this helps us to determine if there are any non-kidney related factors that are involved in this kidney disease, such as, let's say, a low carbon dioxide level or WBC destruction. And when the blood volume decreases, your cardiac output is also going to decrease. So that's going to make the BUN go up more rapidly than the creatinine. So as a result of that happening, the BUN and the creatinine ratio is also going to go up. When both of these are up, it is suggested that there is some type of a kidney dysfunction going on. Another lab test that we see sometimes done is the blood osmolality. And that's usually 280 to 300 millimoles or milliosmoles. And it's a very good indication of how well hydrated our patient is. When the blood osmolality decreases, there is a release of the vasopressin, which is your antidiuretic hormone, if you remember. It's inhibited. The release of this hormone is inhibited. And it makes the tubules not permeable to water. So it's excreted and it's not reabsorbed. So therefore, the osmolality increases and the ADH is excreted. Water is reabsorbed and the osmolality decreases. So that's just kind of a quick review of that. So we already talked about your sodium, your potassium, phosphate, often elevated in kidney disease. Our normal phosphate levels is 3 to 4.5, and they're usually going to be elevated in kidney disease. Now, the calcium, which is usually around 9.5 to 10.5, is going to be decreased in kidney disease. We also want to look at the urinalysis, like we mentioned before, and we're looking for the protein and the RBCs, the color, the turbidity. Specific gravity is also a very good indication of how well the kidneys are being perfused and how hydrated the person is. The specific gravity, the normal is 1.005 to 1.030. It's going to be elevated whenever the kidney perfusion is decreased, when such as in heart failure or let's say inappropriate secretion of ADH. It's also going to be increased with chronic kidney disease, diabetes insipidus, malignant hypertension, use of diuretics, and lithium toxicity. pH of the urine is, the average is around 6. So when we talk more about our kidney stones and everything, we'll talk more about the acid and the alkalinity of urine. But typically we like to see the average around 6. And it can be anywhere from 4 to 6.8. Not everybody's going to be right on 6. In a 24-hour urine specimen, the glucose is usually anywhere from around 50 to 300. And we should not be seeing any ketones, acetones, bilirubin. If there's nothing going on with the liver, we should not be seeing any of that stuff. We should not be seeing any bacteria unless they have a urinary tract infection. And then, of course, we may need to culture the urine to see what type of bacteria it's growing to make sure that we cover it with the appropriate antibiotics. So what are some of the interventions that we want to employ with these patients? Well, first of all, we want to slow the disease process. We want to manage any type of infections that they have going on with antibiotics and offer them supportive care, modify their immune system. If there's medications that we can give them to boost their immune system, then that's what we want to do. We want to prevent any further complications of the disease process. We want to prevent end-stage renal disease if at all possible. And then we also want to prepare our patient on how to manage themselves. How can they take care of themselves at home? What kind of diet do they need to be on? When do they need to notify their physician? Make sure they know they need to keep all of their doctor appointments so that we can continue to follow them closely with this kidney condition, so that hopefully it does not develop into anything long-term for them. Okay, now let's talk about chronic glomerulonephritis. It's a condition that is characterized by irreversible and progressive renal disease, leading to the reduction of the filtration rate and the retention of uremic toxins. So when you think about your kidney patient, think about their color is usually a sallow color. They are usually edematous. They may be short of breath because of the edema. Their urine output is usually going to be low or maybe even completely absent. They may not have any urine output at all. And then some of the reasons that this happens can be a cardiovascular disease. Maybe there's a problem with the vessels in the renal arteries. Maybe the blood supply is not getting to the kidneys as it should. Sometimes we can actually have acute tubular necrosis from surgeries if we have a patient that may have had a triple aneurysm repaired, or AAA. Because those renal arteries, when the procedure is done open, which means that they open their abdomen, they have to go in there and clamp off those renal arteries in order to do the grafting. And that cross clamp time means kidney time. So the longer that cross clamp time is, the greater incidence it is likely that they may have some type of a renal injury from that. So where does it come from? Usually it happens over time. It's usually not something that happens just over the course of a week or two. It can be caused by scar tissue. Maybe they had some type of injury, or maybe they had some type of a disease when they were younger that left them with scar tissue. They may be already a dialysis or a transplant patient. And that doesn't mean that they can't have renal failure again. They certainly can, depending on what caused it in the beginning. And progression varies. It just varies with the individual person and with whatever else is going on with them. If they have a lot of other comorbidities such as diabetes and hypertension, then they're going to be more likely to progress onto chronic renal failure. And there's different stages of chronic renal failure. You'll see on a patient's chart, they may be in stage 2 or stage 3 of renal failure. So just be aware that there are different stages. So what are some of the clinical manifestations that you're going to see in these particular patients? Well, you're going to have uremia, and you may see the uremic frost, particularly if they are critically ill. Just like the other patients, they're going to have the swelling, they're going to have the hypertension, neck vein distension, rales, a pericardial effusion or a pericardial rub related to a pericarditis. And basically what this is, it can be 1, 2, or 3 extra sounds in the heart. And it's like a grating, scratching sound if you listen very closely to the heart. And it's heard with pericarditis, which is an inflammation of the pericardium. And it causes the walls of the pericardium to rub together, and it causes that grating sound. Typically, it is heard best at the apex and the sternum. Now, as far as treating pericarditis, NSAIDs can be used for pain. It is an inflammatory process. So NSAIDs or aspirin can be used for pain. Sometimes they use steroids, but they may suppress the immune system or the symptoms, but they don't accelerate the cure of the disease or the condition. And it can actually lead to recurrence of the disease. So that kind of has to be based on the patient and how sick they are and how, what kind of problems they're actually having with the pericarditis. Epigastric tenderness may also be a problem. Blood in the stools may be a result of the uremic gastritis or enteropathy that may have occurred. And remember, our stress ulcers, these patients may also be prone to stress ulcers because of the debilitating disease. They may have decreased sensation or asphyxia in advanced uremia. And asphyxia is tremors of the hand when the wrist is extended, and it can result from too little or too much certain vitamins and minerals that cross the blood-brain barrier, and it causes neurological misfiring. So that's what causes that flapping type sensation in their hands whenever they try to extend their wrist. These patients may also complain of itching. Their skin may also be a little yellow, like a sallow yellow color that I talked about earlier. And they may have other type of problems going on as well. Generalized discomforts. These patients are just miserable most of the time. They're some of the sickest patients that you will probably ever see that survive and go home. They may have cognitive changes because of the changes in their vitamins and mineral levels. They may also have memory changes related to the toxins that are not being excreted properly throughout the system as well. Their speech may be a little unclear, especially slurred, especially if their disease is progressing. They may actually be incontinent too, if they have any urine output at all. And usually they can tell you if they have urine output or not. So how are we going to assess these patients? The same way as the others. We're going to listen to their lungs. We're going to assess their weight, their blood pressure, their vital signs. Do they have any neck vein distension? We're going to look for swelling in their feet, legs, scrotum, and shins. So basically from the waist down. They may complain of itching, and they may scratch and scratch and scratch, and they may actually impair their skin integrity from the scratching because the toxins are excreted in their skin, and it makes them itch a lot. And then we've already talked about changes in the urine output. The diagnostic tests are very similar to the acute glomerulonephritis. Ultrasounds may also be helpful with these patients because you can tell you what's going on with the kidneys. Is the kidney too large? Is it too small? Has it atrophied? And what's going on with the structures around it as well. And so that may be very helpful. And then ultimately, we may end up needing a biopsy to determine exactly what the cause of their kidney problem is, and determine what treatment would be most appropriate for them. So how are we going to treat these patients? These patients can have a very, very stubborn blood pressure. It's not uncommon for them to be on 3 or 4 medications. The angiotensin converting enzyme inhibitors is probably one of the most commonly used because it actually helps to dilate the venules and the arterioles, which in turn helps to improve the renal blood flow, and it decreases the blood volume. Also, it helps to decrease the release of the aldosterone, which in turn, as you remember, decreases the sodium and fluid retention. Now, with these particular medications, we have to watch their potassium, because their potassium may also be elevated with these particular medications. And this is going to be like your captopril, your lisinopril, enalapril, or your Vasodex. So those are the most common ones that you're going to see there. Now, the next category of medications is the angiotensin II receptor blockers. And this particular group of medications causes the vessels to enlarge, which, of course, drops your blood pressure. It also helps to prevent the release of aldosterone. And as you remember, the aldosterone is a sodium-retaining hormone. And these drugs also act on the renin-angiotensin-aldosterone system, and we'll talk a little bit more about that in a couple of minutes. It blocks the angiotensin from the angiotensin 1 receptors in many of the tissues, and it is usually a very well-tolerated medication. However, its safety has not been proven in pregnancy, so they do not recommend that pregnant patients take this particular category of medications. And your most common ones is the valsartan and losartan. Those are the two most common ones that you're going to see. And most of the time, these are used in combinations. Aldosterone antagonist is another group that you see used occasionally. Spironolactone is one that fits into that category. And it is used because it is potassium sparing, because we don't want to pull too much potassium off. And it also helps to block the production of the aldosterone. Now, it can also affect the heart rate. It can cause variability in the heart rate, and it can also decrease the cardioprotective mechanisms of the aldosterone. Diuretics is also one of your first line drugs to use for decreasing the fluid volume. Furosemide, torsemide, Bumex are all common diuretics. And these have to be used in very high doses most of the time with these patients. So your 20 or 40 milligrams that you would use in your regular patient is going to be totally useless with these patients most of the time. You're going to have to be giving these patients anywhere from like 80 to 120 milligrams of the diuretic. Calcium channel blockers are also another group that may be used because they actually block the calcium channel in the vascular smooth muscle, and then that in turn promotes vasodilation. So therefore, the blood pressure is going to drop, and it's going to increase your kidney perfusion. Verapamil, deltalizam, amlodipine are your most common examples of that. Now, with the renin-angiotensin-aldosterone systems, the kidneys, I want you to remember, is the major regulator in sodium and water. So when the sodium and water changes, there's a change in the blood pressure, there's a change in the blood volume, there's a change in the oxygen level in the blood, and the blood osmolality also is affected by the concentrations of the sodium. So when your kidneys sense a change in one of these parameters, they begin to excrete renin, which sets into motion the group of the hormones and blood vessel responses to ensure that the blood pressure is raised back up to normal so that the kidneys aren't screaming because of low perfusion. And then by this event being triggered, there's changes that are signaled in the kidney tissue to decrease the risk of injury from lack of perfusion. So you're going to have a lower blood pressure, low blood volume, low O2, low sodium. Where sodium goes, the water always follows it. So anything causing too little sodium, it prevents water from staying in the blood. And this is all going to result in a decreased blood pressure and poor perfusion. And then once your kidneys sense that, hey, something's going on and I'm not being perfused like I should, there's special cells in the kidney tubules that secrete the renin. And then the renin in turn activates blood protein, which is angiotensin or angiotensin 1. And it has little action, but there is another enzyme called angiotensin converting enzyme, which converts the angiotensin 1 into angiotensin 2. And that's what makes this angiotensin more effective. By itself, it really isn't very effective, but when you combine it with this angiotensin converting enzyme, that's whenever it starts to become more effective. And then, of course, as you know, the angiotensin 2 starts several different processes. It starts activities to immediately increase the blood volume and the pressure. It causes vasoconstriction, especially in the peripherals, to increase the blood flow to the more central organs. And this is a compensatory mechanism that our body has without adding more volume. So this is something that our body just does automatically. It also constricts the arterioles that feed the kidney nephrons. And this results in a lower glomerular filtration rate and a decrease in the output. So a decrease in the output prevents further water loss, and more is retained in the blood so that it adds extra volume to the blood, and it can raise the blood pressure to help kidney perfusion. The last action that is caused by this angiotensin 2 is a little bit slower. It causes the adrenal glands to secrete aldosterone, which causes our kidneys to reabsorb the sodium and the water, and less is excreted in the urine. So therefore, more sodium and more water is retained in the blood, so more blood volume is retained and your blood pressure is higher because you have more blood volume. Okay. We've already talked a little bit about this. Only about 1% of these cases proceed to end-stage renal failure. And most of the time, kids are resilient with this. They do very well and are usually quick to recover from it once it's diagnosed. So what are some nursing considerations that we want to think about with these patients? Well, we want to think about fluid overload, which we've already talked about. How are we going to assess for that? We're going to look at their neck veins. We're going to listen to their lungs. We're going to assess for any peripheral edema. But just remember that peripheral edema is a later sign. That's not something that we see early on. Early on, you're going to see the neck vein distensions. You're going to hear the crackles in their lungs. You may hear them start with a little hacky cough that they didn't have 4 hours ago. So if you hear your patients start doing that, you need to go assess them to see what's going on and why are they doing that? Are they going into fluid overload? So sometimes that's your only warning sign. And if you can ward that off, it can mean a lot for the patient as far as their recovery. They recover a lot quicker if they can be kept out of fluid overload. Ineffective protection, depending on what has caused their renal disease, if it's something that is an autoimmune disorder or if they are chronically ill with it, they may be one that is prone to pick up other germs and bacteria very easily. Ineffective role performance, it may be a person that has been the sole breadwinner in the family, or maybe they've been taking care of another sick family member and now they can't do that because they're sick themselves. So that may be a psychosocial aspect that we need to look at for these patients. Risk for skin integrity, we've already talked a little bit about that due to the toxins that are excreted in the skin, and it causes it to itch and they scratch it. So they may need some of the Eucerin creams, some of the thicker, heavier creams to help with that. We want to make sure that that cream is not fragranced and that it doesn't have alcohol in it, because that will definitely burn if they've got little broken areas where they've been scratching. Risk for decreased cardiac output, we've already talked about that because the blood pressure drops. Therefore, the cardiac output is also going to decrease. Disturbed thought process may be related to the accumulation of toxins that the person has. They may have knowledge deficit of their disease process. They may know that they have kidney failure, but they may not know to what magnitude. And so it's as our role as healthcare providers is to verify that these patients do understand what is going on with them and things that they can do to help slow down their process so that they don't end up on dialysis or hemodialysis or peritoneal dialysis. Pain, these patients are usually going to be uncomfortable because basically what is happening is those toxins are being held on to within the body. So if they're held within the body, then that's going to cause irritation to the nerve endings, and it's going to make these patients very uncomfortable. They're going to feel just really achy and sore all the time. Their nutritional status may be something that needs to be addressed. It may be that they're eating all the wrong foods, or it may be that they're not eating enough. So we may need to consider having a dietary consult so that we can increase their calories without increasing the protein and other nutrients that they really don't need because of their kidney disease, because we don't want to put more stress on their kidneys than they already have. So does anybody have any questions for me? No questions? Okay, we will move on to the next one. And then after that one, I will give you a break. Okay, let me answer this question. So if we hear a gallop in a 2 to a 12-year-old patient, is this normal? Well, typically, you're not typically going to hear a gallop in a 2 to a 12-year-old that is normal. You may, and it may be perfectly normal for that child. They may need to do an echo on it to determine if there's anything else going on or not. And if, of course, like we said before, if the person is very athletic, they may have a gallop. So does that answer your question, Tracy? Tracy? Okay. All right, let's move on to the next one. No questions, right?
I don't have a question. Maybe it's a question. So with glomerulonephritis, if you have strep throat, we encourage the patients to finish the full prescription of the antibiotic. Could potentially be a preventative measure, or will they still be at risk for it, even if they take the antibiotics and they have strep infection?
They could still be at risk for it. You're right, it's very important for them to finish taking the antibiotics, but they could still be at risk for it because the bacteria can settle in their kidneys. Does that make sense?
Yes, ma'am.
Okay. All right. Okay. If nobody has any questions, we're going to move on to cancer of the colon and the prostate. Okay. Can you see the PowerPoint? Can you see everybody can see the PowerPoint? Okay, perfect. I just want to make sure. I can on my end, but that doesn't necessarily mean you can on your end sometimes. So, okay. So now we're going to talk about some colon cancer and prostate cancer. Okay, I've included your objectives here for you to read. I'm not going to read them to you. So colorectal cancer or colon cancer, the terms are interchangeable, can be used for a cancer that is in any part of the colon or the rectum. It can be also known, like I said, as a colorectal cancer. Most of these cancers are adenocarcinomas, which means that they arise from the glandular epithelial cell in the colon. Polyps, if you will remember, they form an increased tissue proliferation, and then they often progress into malignant cells. And colon cancer is the most common type of internal cancer that does originate from the epithelial cells of the colon and the rectum. 2/3 of the colon cancers occur in the rectosigmoid colon. And when we're talking about metastasis, it usually occurs in the blood and the lymph and liver. And do you have any idea why that is? Any thoughts on that? Well, think about how vascular all of those are. We have our blood system, which is very vascular. We have our lymph system, and then the liver is very vascular as well. So they have a nice, all of those systems have a nice, healthy blood supply to them. I've included these incidents here for you. This is not something that I'm going to expect you to remember on your test, because I don't feel like this is something that's going to help you take care of your patients. But it was just some interesting statistics that I ran across whenever I was looking at my own research for this topic. So let's talk a little bit about the risk factors. Usually if people are older than 50, but now that doesn't necessarily mean that somebody that is younger than 50, as you know, could not have colon cancer, because that does happen occasionally. Genetics is also thought to be linked to possible development of colon cancer. Certain diseases, such as we talked about these the other day, your inflammatory bowel disease, and your FAP, which is familial adenomatosis polymyositis. So that's just another genetic hereditary development of polyps in the large colon and the rectum. So it's just a fancy name for developing those polyps in the colon that is hereditary. Other factors that come into play include smoking, obesity, sedentary lifestyles, diet high in fat, and then, of course, the use of alcohol. Polyps of the rectum and the large intestines has been linked to previous gallbladder removal. Sometimes some research has shown that people have had their gallbladder removed, and then they've developed polyps of the rectum or the large intestines. And I don't know all of the variables in that particular research project. I did not read all of them, but I'm sure there's a lot of variables that come into play with that too. And we were talking about diets that are high in fiber, high in fat content. And then if we lack fiber in our diet, lacking fiber causes the food to stay in our colon longer. So therefore, it prolongs the exit of the body. So that can give us more of a chance to be exposed to possible carcinogens because it just moves through our GI tract much slower. And I put this picture in here for you so that you could kind of have a visual of what was going on with the intestinal tract or the colon when we have different stages. You can see we have just hyperproliferation of the tissue on the left, and then as we move over toward the right, you can see the adenocarcinoma, which is what most of the colon cancers are, and then it moves on into the invasive cancer, which invades the muscle and the tissue around the colon. A large amount of red meat has also been one of the culprits of what they think may be leading to colon cancer because of the increased bile acid secretion that occurs whenever we eat red meat. And in 2010, I could not find any more up-to-date research, but it was the third most common cause of death in the United States. So it does happen. It's can be kind of like a silent killer too. So this is a picture of some polyps. I wanted to put this on here so you could kind of have a visual of what they look like. They just look like little pockets of or little tags within the colon, and this person has lots and lots of them. And if you look at the tissue on the one over to your right, you see how more granulated it looks down close to the skin. So you can see there that the cells are beginning to change as opposed to the one that is adjacent to it toward the left. It's very small, very slick and shiny, and you don't see that tissue proliferation like you do there. This is a colorectal tumor. This is what happens whenever you have a polyp or a tumor develops and it's not removed. So you can automatically see how one of the problems with this particular type of tumor could be an obstruction because it's so big that it just would completely obstruct the large intestines. Tumors in the transverse and the descending colon are more likely to cause obstructions, gas pains, and incomplete evacuation. And if you think about where they are, it stands to reason why these things happen. And if they have an obstruction, they could potentially have a perforation as well. And then all of that content is dumped out into their abdomen. Okay, tumors in the rectosigmoid area are more likely to cause rectal bleeding. Hematochezia is the term for rectal bleeding. And the person may have a change in their stools. They may have a lot of straining with their stools. They may have a dull pain. And the stools may actually change their appearance. They may be more narrow than they were 6 months ago if the tumor has progressed. Right-sided colon tumors can grow large, and most of the stool, as you know, in this area is liquid. So the bowel pattern may not necessarily be interrupted because it's liquid to begin with. Now, one problem that these patients can have with these tumors is that they can ulcerate, they can bleed, they can lead to anemia, they can lead to significant blood loss. Typically, if you hear high-pitched tinkling bowel sounds, that may indicate a partial obstruction. No bowel sounds, of course, is going to indicate a complete obstruction, but you have to look at your whole picture. You can't just look at the abdomen alone. You have to look at what does your whole patient look like? Is their color good? What's going on in their history? Have they had any changes lately? So we have to think about all of those things. And with the digital rectal exam, we might actually even be able to feel rectal or lower sigmoid masses if they're low enough in the colon. And if you are going to do a fecal occult blood from a specimen from a rectal exam, chances are it's not going to be reliable, because if they have any hemorrhoids or anything in there that's going to cause any bleeding, then that's not going to be a very reliable source for you to depend on when you're assessing your patients. So what are some of the things that we can teach our patients to do? Well, we of course want them to make sure that they have a colonoscopy if they're over 50 every 10 years, and a fecal occult blood test as well. That's what the FOBT is. If they have a personal history or a family history of any type of colon cancer, polyps, anything like that, then they need to be monitored more closely. So we would want to definitely monitor them a bit closer for that. So what are the signs and symptoms? We've already talked a little bit about that. Depending on where the tumor is, it can be rectal bleeding, it can be anemia, changes in the color and the consistency, shape of the stool. The stools may be bright red, they may be dark tarry stools, depending on where the problem is in the colon. Typically, whenever you have a tumor in the descending colon and the rectum, you usually do not have a problem with weight loss, anemia, nausea, and vomiting. So those can be a bit sneaky. So people can have those and don't realize they even have them because they don't have any significant signs and symptoms until the tumor has progressed significantly. Other tests that we might want to consider for these patients too is a colonoscopy, especially if they've had any type of polyps removed. Then they're going to need testing more often than every 10 years. CT or MRI may also be helpful, but that also helps us look at how big the mass is. And it also helps us look at how extensive the disease is. Has it spread to other surrounding tissues? Blood tests may be the H&H. We want to look at their hemoglobin and hematocrit. Liver function tests to see if they're elevated, especially if there's any type of liver metastasis going on. CEA, which is a carcinogenic embryonic antigen, it should be less than 5. It can be elevated with a malignant or a benign disease, and it's also a bit higher than that in smokers as well. So those are things we need to keep in mind. Sigmoidoscopy is also another test that we do. We don't do those that often anymore. They used to do those occasionally at the bedside, but we don't do those very much anymore. They just do a whole colonoscopy if they're going to, which only looks at the large intestines, but it allows them to be able to visualize the entire large intestines for the most part. And the sigmoidoscopy is only looking at your lower part of the colon. So we've already talked a little bit about some of the complications of colon cancer. Obstructions, perforations, we can have pockets of abscess that form in there, peritonitis, fistulas. We talked about fistulas the other day, is when two tracts meet and form an opening to the outer portion of the body in some area. So what are some other signs and symptoms? And when you look at these signs or symptoms, like the cramping and the pain, there's a lot of other things that could be attributed to. So we have to be very mindful about that whenever we are trying to rule out this problem with the patients. And sometimes patients come into the emergency room, and the first time you ever lay eyes on them, they have an inoperable mass that they did not know that they had. But our success rate for cure is very good. It's 70 to 90% if it's found early. So that's why it's so important to get these patients to do these screening techniques. Some of the lab values, we've already talked a little bit about that. The hemoglobin and hematocrit, of course, you're going to want to make sure they don't have any anemia going on or any other type of blood dyscrasia that may be indicative of another problem. The AST, ALT, we want to look at their liver. Alkaline phosphatase is going to let us know if there's any type of bone metastasis going on. We want to avoid aspirin and vitamin C if they're going to do a fecal occult blood stool. And now we have those that they can actually send in. They don't have to actually go into the office to get it. What is it, Cologuard? Is that the little guy sitting on the box, the little blue guy with his little feet dangling on the box? I think it's Cologuard.
Yeah, that's the one, Cologuard.
Okay. So see, they can even do that in their own home. Now, I don't know how expensive those are. And I know that, a lot of our older population do live on fixed incomes, and that might not be something that they would invest in if they had to buy it. And Medicare may pay for it. I'm not sure about that, but that's something to think about too. The CEA, we've already talked about that. It should be less than 5. It should actually be less than 3 in non-smokers and less than 5 in smokers. So theirs is going to be a little bit higher.
Cologuard is covered by insurance.
Is
Medicare.
it?
Yeah, Medicare and private insurance.
Do you have any idea how much it is? I'm just curious.
Oh, the price? I'll look for you.
Okay, I'm just curious about that. I hadn't looked that up.
$649.
Ooh, that's quite expensive.
Yeah, most insurance will cover about 50 to 70% if it's like a private. And, there's things, especially like if your doctor, because something like that, the doctor, the provider can, input some information to make it so it's like, listen, they really do need this. Sometimes they just need that push and they may just cover it. But Medicare, Medicaid will cover the whole thing.
Perfect. That's wonderful. It's wonderful to have that. And then if we can just educate the patients on the importance of doing it and following up if there is a need to. So, that's really great. We've come a long way. There's also another test. It's a capsule that is swallowed and it has a camera in it. And it takes pictures throughout the entire GI system. So you get the small intestine as well. I think it takes a picture like every 30 or every second as it passes through the GI system. The problem with that is that you have to be able to find it in your poop and then turn it back in so that they can look at what's on the camera. So some people aren't too enthused about that. I don't know. I would rather do that than the prep for the colonoscopies because those are no fun. So, okay. We've already talked a little bit about some of the procedures that we can do. The double contrast barium enema, you have to be very careful with that because that can cause a perforation in the colon, especially if there's a tumor that may have necrosed some tissue in there. You have to be very careful about that to make sure that we don't perforate something. And then the good thing about the colonoscopies is that it's kind of like a one and done deal. You can go in, you can look around, see what's there, and then you can do biopsies on anything that looks out of the ordinary or that you're concerned about. So it definitely has its advantages as well. So staging and metastasis. We're going to talk a little bit about the different staging and metastasis in just a couple of minutes. I've got a little chart on here for you to look at. it can metastasize by invasion or by extension. It just depends on, it can invade other tissue, or it can extend past the area that it initially started in. And your most common sites is going to be your liver, lungs, brain, bone, and adrenal glands, because they are so vascular. So that makes them a little bit more prone to develop the cancer. Now, this is the tumor staging chart. I don't expect you to remember everything on this chart, but the main thing that I wanted you to know is that if you see on a patient's chart that they have a T and then they have an N that maybe has a 2 by it, and then they have an M that has a 1 by it. What does that really mean? Well, if you look at the T, that means that there is definitely a tumor there. 2 is indicative of nodes. Is there any nodes, metastasis to the nodes? If they took out 15 nodes, does 1 node or 8 nodes have metastasis? Because that kind of gives you an idea of how advanced their disease is and what the treatment might be. And then the M, of course, is going to let you know if there is any metastasis to any distant tissue. So that's kind of what that breakdown is. I just wanted you to be familiar with that. So when you see it on a patient's chart, you'll kind of know what you're looking at. And it's like, oh, okay, well, they have a T2 and they have an M0, so that means it hasn't metastasized anywhere. And they have an N1, which means that there was metastasis noted in 1 to 3 of their lymph nodes that was dissected at the time of surgery. So that's what I wanted, the point I wanted you to get with that. Now, there's several different kinds of treatments. Surgery, which can be a colon resection. Sometimes these patients can end up with a colostomy or an ileostomy, depending on where the tumor is. They may end up with a colectomy. They may just have a colon resection. They may be able to go in there and just take out a very small section of the colon where the tumor is, anastomose the ends of the colon back together, and they're good to go. They don't have to have an ostomy. Now, they may also do an A&P resection, and when they do those, typically they close up the rectum. So if you have a patient that comes back to you from surgery that has had an A&P resection, their rectum is usually going to be closed up. Now, they're going to continue to have some bloody drainage from that rectal area because of the surgery, and they may also continue to have some mucoid stools, just a stool that was left over from before the surgery. So don't be surprised about that, because you'll think, oh, they're not supposed to be having anything, coming from the rectum, because they sutured it up. And don't try to take a rectal temp either, because that won't work. So just make sure you know that, and just prepare for a lot of dressing changes, because these patients have a lot of drainage most of the time with A&P resections. Radiation. We've come such a long way with the radiation, because we can pinpoint the area so much more precisely than we could 10, 15, 20 years ago. So we don't damage as much good tissue as we have in the past. We only try to aim it more at targeting the cancerous tissue. And then, of course, chemotherapy is usually recommended for stages 2 and 3, and it's usually given in cycles. And we're going to talk a little bit about the chemotherapy. I'm not really worried about you knowing the names of the chemotherapy, because there are so many and they're changing daily. But I just wanted to give you an overview of the most common agents that are used, and we'll talk about those in just a second. And here's another ostomy. This is a pretty one because it's very shiny and pink. It's got a very good color to it, and it's like about 3/4 of an inch above the skin, which is good because the stool's going to come out and dump over into your ostomy pouch. So you should not have a problem with it running under the wafer or getting on your patient's skin. So if you have to have an ostomy, this is a nice one to have. So, and it's healed up very nicely too. You remember the one we saw the other day had the sutures around it? Well, see, we're already past that stage with this one. Those sutures are already gone, and you can actually see the imprint of where their wafer has been. And it fits nicely because they don't have any skin irritation from the acid in the stool either. So the stool's not getting on their skin. This is some of your most common chemotherapy agents. They typically, it depends, they can be used pre and post-operatively. Sometimes they use the chemo and the radiation to shrink the tumor if it's big, to try to shrink it so that they don't do any more damage than absolutely necessary. And these can also be used just for palliative care, to control pain and maybe help control some of the bleeding that may be going on with the cancer. And Flofox is probably the most common one that you're going to see. It's the combination of these three particular drugs, typically combining these measures with the chemo, radiation, and even surgery will hopefully improve the outcome if they do not already have metastasis going on. And sometimes they just will have to put a stent in. There's nothing more that they can do other than putting a stent in to keep the bowel open if the person's a candidate for surgery until they're well enough to take to surgery, or it may be just something that they're going to leave them in all of the time. Any questions about that?
So you said, so for the chemo, we don't need to necessarily know the chemotherapy drugs, just the nursing interventions and side effects. Okay.
Right. Because they change daily, I think. So the main thing is just knowing, the complications that your patient's going to have. How am I going to take care of this patient? Those are some of the things that we want to talk about too, because some of the side effects of these medications can be pretty wicked. And one of the things that I didn't mention to you when we were talking about the stoma, you always want to make sure that you monitor their output, any drainage at all that they have from it. And they can have drainage, they will usually have a bloody drainage early on. And then over the course of the next few days, usually takes about anywhere from 2 to 4 days for a colostomy to start functioning. And you want to, of course, to avoid any heavy lifting or straining, because we don't want any tension on that side or any of the anastomosis sites inside. Rectal bleed, if they have rectal itching, which may be caused by the sutures, they can have, usually they would let them use benzocaine for that. It's a topical anesthetic. Or they may actually let them do a sitz bath too, which is very helpful, just to sit in the warm water, because that's very soothing to their bottom whenever they're having a lot of irritation. So we know that chemotherapy kills good cells as well as bad cells. So it's going to kill cells in the entire GI tract, our hair, nails, the hair falls out. We have bone marrow suppression. And with all of these effects going on, we're going to have the nausea, vomiting, soreness in the mouth, the sores that prevent them from eating, alopecia. And with the bone marrow being suppressed, they're going to have a low white count. So that's going to make them more predisposed to any type of infection. So we have to be very mindful about that. And sometimes when they go in to get their treatment, their white count may be so low that they don't qualify for a treatment that particular day. They may have to wait a week or two and then come back and be reevaluated for their chemo treatment. So some of the interventions that we've already talked about is, of course, assessing your stoma, offering them a sitz bath if the physician orders it, pain management. And just remember that whenever we're using narcotics, it's going to slow down the motility in the colon. So that may slow down your output as well. Any type of wound care, if they have an open incision or an incision that over to the side from the ostomy, then, we're going to have to assess that. Sometimes that will be left to heal through second intentions. And we talked about that the other day too. They may come back with a JP drain that has to be emptied every few hours or at least once a shift. We need to make sure we monitor what color of JP drainage that they have in the drain. And you also want to make sure if the doctor has ordered for it to be charged, that you want to squeeze it, because that's what makes it active and makes it pull that drainage out. Because if you don't have it charged, then it's not going to have a way to pull out that drainage that he may want to remove. And then, of course, you're going to want to offer your patient any type of education that they may need. And you're going to have these patients that are not going to be interested in managing their ostomy whatsoever. And they will tell you up front, I'm not going to do this. I am not going to apply the wafer. I am not going to manage it in any way or shape or form. So, and that's okay. But we have to have somebody in their family or a friend or somebody that's going to take on the responsibility of helping them to manage this, because when the wafer pops off during the night, who's going to replace it? Okay, so some of our nursing concerns would include constipation due to the lesion, acute pain because this tumor may be constricting the blood flow to a certain area in the colon, and it could actually cause necrosis of part of the colon and cause it to die. So that could also be a complicating factor. Fatigue related to the anemia and the anorexia. They're not eating and drinking as much, so we have an imbalance in our nutrition. We may have a fluid volume deficit because of vomiting and dehydration that they may be experiencing. They may be experiencing a lot of anxiety, especially if they've recently been diagnosed and now they're facing surgery and they're not sure if they're going to come out with a colostomy or an ileostomy. So there's a lot of unknowns, and they're very fearful of the unknowns, which is, to be understood. Then we also have knowledge deficit, which we've talked about before. The surgical procedure, what's going to be done to me? Am I going to come out with a colostomy? Am I not? Am I going to survive the surgery? How am I going to take care of myself at home? Do I have somebody to take care of me at home and to help me with managing my care at home? What type of skin integrity issues do I have? Is the fecal content leaking onto the skin and causing me to have skin irritation? Because that stool just eats up. It's very acidic. And if it gets on the skin, it just kind of eats it up. It makes it very red, very inflamed. They can develop fungal infections there as well. And then what type of body image is the patient going to have? If it's somebody that's young, and it may not necessarily be young, but we think of our 20, 30-year-olds maybe more self-conscious about their body image than our 60, 70-year-olds, but they may be very concerned about their body image. And if they're not married, well, how am I going to explain this to anybody that I might start dating or want to have a relationship with, or maybe the type of work that they do? It may be a problem to manage it with that, at least early on. So we have to think about all of those things whenever we're trying to educate these patients. We just try to touch on everything that we think might be a concern. And then you're going to have other patients that they have no worries at all about it. They're not one bit concerned about the colostomy or the ileostomy. We need to be mindful about what kind of foods stimulate their appetite. They may need TPN or PPN postoperatively. We typically like for these patients to be on a high protein, high calorie, low residue diet because that is going to promote healing. And also, another thing that these patients are concerned about is odors that come from their colostomy. So foods that might be odor provoking, maybe your broccoli, your beans, your spicy foods, onions, cabbage, cauliflower, mushrooms, peas, they all cause a lot of gas. And so does chewing gum and smoking. So these things, if we can get them to eliminate some of these things, and eggs, fish is also very bad at causing a lot of foul odor, turnips, asparagus. We can all help them alleviate some of those concerns as well. Some of the ostomy pouches also have you can get a charcoal filter to go in them that helps to deodorize them. Crackers, toast, yogurt, things like that's going to help prevent gas. And things like buttermilk, cranberry juice, parsley, and yogurt are more likely to prevent odor as opposed to some of those other foods that we talked about. So do y'all have any questions for me? Okay, why don't y'all take a 10-minute break and then come back and we'll finish this one up, and then we'll do stones and we'll be finished. So I can keep you on track. Can everybody hear me?
Yes.
Okay. Okay, so our next topic is going to be prostate cancer. It's the most common cancer in American males. Actually, African American males are more affected than just Americans. So African Americans are more affected by this. It's usually very slow growing, and it is usually androgen sensitive, which means it's related to testosterone, and we'll talk a little bit more about that in a few minutes. Typically, your male is going to be 65 years or older that is at the highest risk for it. That doesn't necessarily mean that they can't have it earlier than that, but this is just the typical age that we see it becoming more prevalent. And this is something that we've already talked about. You know, testosterone is definitely the dependent factor on how fast and what kind of cancer it is. The cancer can spread to other areas such as the bladder, the seminal vesicles, and the perineum, as well as the bones. The spine is a very common site. The hips are a very common site, lung and liver as well. Lymphatic system can also be involved. And sometimes you will have these little patients that come in and they are diagnosed with metastatic prostate cancer. And that's the first time that you see them when they come into the emergency room. They have had such a slow decline over time that they just never sought medical treatment until the pain got so severe in their back that they just couldn't tolerate it anymore. And then that's when they present to the emergency room and they're worked up, and you realize that they have metastatic disease. Okay, I put a picture on here of the prostate gland so that you can see where it is in relation to the urinary tract and how processes that affect it, like BPH, and we'll talk about that Wednesday, but that as well as the cancer can put pressure on the urinary tract and cause problems. Here's some more statistics that I've found that I thought was really interesting, and this is from cancer.org. And it's actually 4% of all of the cancer deaths is related to prostate cancer. 1 in 7 men are going to be diagnosed with it during their lifetime. I think the main thing that we have to think about with these patients is when we're thinking about treatment, is it worth the benefits? Because a lot of times, if you have an 80 or 85-year-old male that is diagnosed with prostate cancer, the likelihood of something else happening to him before the prostate cancer takes a toll on his life is very great. So sometimes they have to weigh the physician and the patient has to weigh the odds as to what's the most beneficial route for us to go with you. Do you want to treat it, or do we just want to leave it alone and just watch it and put surveillance is what that would be called. Let's look at some of the risk factors. Well, some of your risk factors includes the age, advanced age, which that is your primary risk factor. We've already talked about race. Occupational hazards may also be a risk factor that comes into play in some patients' lives. Their diet, what kind of diet do they have? Do they have a diet that is high in fat? Do they have a family history? If they have a first-degree relative that has had prostate cancer, then that doubles their risk for developing the cancer as well. So that's something that we need to make sure that they're very well educated about. So let's talk about the health maintenance. How can we help these patients stay as healthy as possible? Well, screening is one of the first things. Now, the PSA is not recommended for screening as much as it one time was. So that's something that has to be decided between the patient and the physician. A digital rectal exam will determine a firm, abnormal, hard mass just inside the rectal wall. You can feel it through the rectal wall, especially if it's very large. And that's also the way that they determine if people have enlarged prostate problems as well. What kind of lifestyle does the patient have? We need to encourage them to have more active lifestyle and maybe cut back on the amount of fat and the complex carbohydrates that they have in their diet. Increase the fiber. Because remember, we talked about the fibers, low fiber slowing down the transportation of the body's excretions. So if they're slowed down, then we have more of a chance of exposure to the toxins that may be in some of the foods. Arsenic is also another one that has been proven to be a cause of prostate cancer. And there's also been some link to people having had vasectomies. They may also be at a higher risk for developing prostate cancer. So basically, what the patient needs to do is discuss it with their physician to see which route is the best way for them to go as far as their screening and diagnosing. So what type of signs and symptoms are we going to look for? Well, we want to look at their difficulty in urinating. Do they have problems starting their stream? Do they have a weak or interrupted stream? And just be mindful that a lot of these signs and symptoms go along with BPH as well. So it's not necessarily indicative of prostate cancer, but it certainly warrants investigation. They may be unable to empty their bladder completely, so they may feel like they have to void all the time. And, we've all encountered little patients like this in the hospital who have to get up every hour to pee 50 cc's. So that's something that's important to think about as well. Hematuria, do they have any blood in their urine? Are they up and down every hour, every 2 hours at night? Are they having any type of pain? Are they experiencing weight loss? Any lymphadenopathy? What is their nutritional status like? Are they losing weight, or is their weight pretty consistent? Urinary tract infections, are they having a problem with those? Are they having pain during intercourse? Do they have a history of any STDs? Are they having any discharge from the urethra? Are they having any edema or pain in the scrotal area? Now, some of the psychosocial aspects that we want to consider with these patients include denial. It's not going to happen to me. Depression, it can certainly be depressing to think that you have prostate cancer and all the possible side effects of treatment that can go along with that. They may be really concerned about inability to maintain their sexual function. And a lot of that will be dependent on the type of treatment that is chosen for their cancer treatment. Typically, gross hematuria, which is blood in the urine, is a late sign. We typically don't see that early on, at least no blood that is visible to the naked eye. So that's typically something we're going to see later. So what kind of lab tests are we going to look at? Well, the physician may order a PSA, which it should be less than, if the patient is less than 50 years old, it should be less than 2.5. Now, if the patient is older, let's say 70, theirs may be 6 or 6.5, and that's okay for them. That doesn't necessarily mean that they have prostate cancer. It just means that their PSA goes up with the aging process, which is not related to prostate cancer, but that would definitely have to be ruled out. The EPCA2 is an early prostate cancer antigen serum marker. And if this serum marker is present, typically they don't have to do a biopsy. They will pretty much know that if this particular serum marker is there, then there is definitely prostate cancer there, because all tumors secrete different substances. So most all tumors have some type of a serum marker, and that's how we identify them, and identify, a lot of times it's used to identify what treatment they may be receptive to. Alkaline phosphatase, it may be elevated if the patient already has bone metastasis. If you have that little patient that comes into the emergency room and they're complaining of severe back pain, and you work them up and realize they have prostate cancer, metastatic prostate cancer, and it's already metastasized to their bone, their alkaline phosphatase level is probably going to be elevated. Now, if they have metastasis to other areas, you're going to see the acid phosphatase elevated, and that's indicative of it being having metastasized to other areas and other organs. We can also do some bone scans, which will, along with CTs and MRIs, and we've already talked a little bit about those before. That's going to help us see surrounding tissue as well as what we're actually looking at. It's not going to be definitive, but it will help us to see what's going on in the surrounding tissue. A transrectal ultrasound may be prescribed, and that's where a rectal probe on the end of a little ultrasound scope is inserted into the rectum, and they do a visual inspection of what's in there, or well, they actually use the sound waves with the ultrasound, but they're able to tell a lot about the structure, you know, how thick it is, and where does it extend to. We may actually need to do a prostate biopsy, and those can be very uncomfortable for guys, because typically they're going to put them in a lift, like with their legs up in the stirrups, and then they're going to go in through the perineal area, and they take lots and lots of little biopsies from different areas because they want to make sure that they don't miss any area. So that's why they take lots of little biopsies, and it's very uncomfortable for them, and they're usually very sore and complain of some significant discomfort afterwards as well. And they may have a little blood in their urine too after they have a prostate biopsy. And this is where the ultrasound probe that I was telling you about, and this is where they can also do a biopsy. If they want to use the ultrasound probe, they can detect the where the prostate is, and then they can insert the needle in through the perineal tissue, and you see the little orange colored gland, which is the prostate. They go in and take just lots of little samples throughout all of that tissue to determine if there's any metastasis or any cancer in one area that may not have shown up in another area. And then this is bone metastasis. You can see that most all of this little guy's bones are affected by it. So some of the complications post-biopsy is, of course, pain, infection, and hematuria, and we've already talked a little bit about those things and how those can be a problem for the patient. So they're going to need to be watched for any type of infection, if they have any changes in their urine, if they have any increase in pain, any increase in bleeding. Those are all things that need to be reported to their physician. The next slide is called the Gleason scale, and I'm not worried about you remembering all the numbers on that scale because it is pretty extensive, but I just want you to know that the higher the number indicates the more aggressive the prostate cancer is, and it's used for staging each individual patient's prostate cancer, and it's usually, they take the results from the biopsy and apply them to this score, and that's how they determine how aggressive their cancer is. And then it also helps them determine what treatment might be appropriate for these patients. So let's talk a little bit about treatment for prostate cancer. Well, it may be a situation that if they're not having any symptoms, we may not do anything. We may just watch and wait. Like I said before, you know, if you have a little 80, 85-year-old man that has prostate cancer, develops prostate cancer, there's something else that may happen to him long before the prostate cancer would ever end his life. And it can actually take up to 10 years to diagnose and to start treatment for prostate cancer. If they have an obstruction related to the tumor, they could have what's called a TURP, which is a transurethral prostatectomy. And that's where they just go in there and take out part of the prostate. Of course, it doesn't come complication-free. A lot of times post-operatively, they may have some sexual dysfunction, and they may also experience some incontinence. They could also do radical prostatectomy and remove the whole prostate. And then an orchiectomy is going to be removing the testicles because that's where our source of testosterone comes from. Now, if the patient has an open radical prostatectomy, they are more likely to experience erectile dysfunction for anywhere from 3 to 18 months afterwards. And hopefully, after that point, they will begin to improve. Viagra may be helpful if patency is not regained, but it just all depends on the individual person. And then, they may have other comorbidities that prohibit them from taking the Viagra. So those are all things that we need to think about as well. Some of the benefits of the laparoscopic prostatectomy is, first of all, it can be done robotically. But some of the advantages of that particular procedure is that it decreases the hospital stay. They have very minimal bleeding. The incisions are usually much smaller because, any of the procedures that we have done laparoscopically are very small incisions. They're not big at all. Decreased time for the catheter placement. They typically recover much faster. You have significant nerve sparing in this particular procedure as opposed to the open radical prostatectomy. And usually you just have fewer complications. Now, if they have the open radical prostatectomy, they're usually going to go home with a catheter, and it's going to be in probably for about 2 weeks, give or take a little. It just depends on the patient and how extensive their surgery was. So that's going to be uncomfortable for them. And it's also going to limit their social abilities too, because they're going to be a little self-conscious about going out into public with a catheter if they can't conceal it under their clothing very well. So how are we going to manage these patients? Let's go back and talk a little bit how we will manage them post-operatively. Well, we want to make sure that they are very well hydrated. We want to implement any type of pain medication that might be helpful to them. And it may be that a PCA pump might be the most effective means of managing their pain. Antispasmodics may be helpful too, because they're probably going to have some pretty significant bladder spasms because all of the surgery is done right there in that area, and that's irritating to the bladder. So they may have some spasms that we need to administer antispasmodics. I know we need to make sure that our catheter is draining, because if our urine has blood in it and a clot occludes the catheter at the end, we're not going to be able to get out the urine that's in their bladder, and they're going to become distended and uncomfortable. So we want to make sure that that catheter is flowing well at all times. We want to get them up and moving. We may have to elevate their scrotum to minimize the scrotal edema that occurs post-operatively. And Kegel exercises, we always think about Miss Beaver whenever we think about Kegel exercises. These can be very beneficial to these patients too, in helping them with post-operative incontinence. And then, of course, just remember that if they have a catheter in, usually that's going to be with your transperineal or your retropubic approaches, and which both of those procedures can be nerve sparing as well. So hopefully they will not have the complications that they would have had otherwise. So now let's look at what our non-surgical interventions may be. Active surveillance, which is basically just watching the patient and watching their lab work to see how things progress over time, if their PSA stays stable or if it starts to rise over the course of 6 months, then that might be an indication that we need some intervention. Radiation may also be effective, but we have to remember that radiation kills good tissue as well as bad tissue. So that's something that needs to be kept in mind. Hormone therapy may be very helpful. Zoladex is one of your common ones, and we'll talk a little bit more about that in just a few minutes as well. But your Lupron is another one in the Zoladex, because they they stimulate the pituitary gland to release the luteinizing hormone. And these drugs kind of help block testosterone actions on the prostate gland. So we'll talk a little bit more about that in a couple of seconds. We may also have a procedure that is called seed implants, which that goes back to the radiation therapy. And it's where they take a large bore needle and they just put multiple tiny little beads. They look like teeny tiny little BBs that you would use in a BB gun. They look like those, but they're much smaller. And they put multiple seeds throughout the prostate gland. And this also helps to eradicate the cancer. Now, if one of those seeds falls out, are they going to replace it? No, they're not. They're going to leave it out. It's okay. And then, of course, the more advanced the disease is, if they have a metastatic disease, that's probably going to involve your chemotherapy as well as removing the testicles. We've already talked a little bit about radiation, some of the complications that it can cause when it damages good tissue as well as bad tissue. They can have diarrhea, urinary frequency, radiation proctitis, and radiation cystitis. And they can actually have what's called hemorrhagic radiation cystitis post-radiation. And it's where they have just a profuse bleeding from the bladder that's caused by the radiation because it damages the internal lining of the bladder. So that's something that we need to be mindful about and watch these patients for as well, and make sure that we educate them on it too, because if they get home after they've had some radiation and they start having a lot of bleeding, then they need to let somebody know so that they can be followed up on. They need to be monitored for anemia, and as well as if they have a catheter in. Well, even if they don't have a catheter in, voiding may become an issue for them, because if there's huge clots in their bladder, they're not going to be able to void around them. And then we've also already talked about the brachytherapy, which is the implantation of the radiation seeds. Now, the hormonal therapy that we talked about just a couple of minutes ago, Lupron and Zoladex is probably your two most common luteinizing hormones that you're going to see used. And basically what happens with all three of these drugs is that they block the testosterone action on the prostate gland. So it's kind of like an anti-androgen drug. And typically it's going to reduce the amount of testosterone, because that's what feeds the prostate cancer. So that's what we want to do. We want the hormone therapy to decrease the amount of hormone that's being released, because we don't want that prostate gland to grow anymore cancerous cells if possible. Now, some of the side effects is just like any other hormone supplement. Some of the side effects can include hot flashes, loss of muscle mass, osteoporosis, breast tenderness, erectile dysfunction, decreased libido, and those may go along. The decreased libido and erectile dysfunction may actually go along with the prostate cancer itself, not necessarily a side effect of the complication of the therapy that the patient has had for the prostate cancer. So if we decide that chemo is the most effective treatment for the patient to have, then if we've tried one mode of therapy and it hasn't worked, then we may want to move on to the cisplatin or the VP16. All three of these are the most common types of chemotherapy that you're going to see used for prostate cancer. Okay, so what are some nursing interventions that we want to look at for these patients? Well, you want to look at, it all depends on the treatment. If it's surgery, you want to think about all of those things that go along with a surgical patient, where you want to get them up and moving. You don't want to have a problem with pneumonia. You don't want to have a problem with blood clots. They may even potentially need a transfusion post-operatively if they bleed a lot. So they need to be aware of that. Radiation therapy, they're going to have maybe skin irritation from the burns, or they may have internal irritation from the burns from the radiation. And then, of course, chemotherapy is a more systematic approach. So depending on what type of chemotherapy they have will depend on the signs and symptoms that they will most likely experience. And I'm not really worried that much about you remembering all the different names of the chemotherapy. I just want you to be somewhat familiar with the generalized side effects of the surgery, the radiation, and the chemotherapy whenever you're caring for these patients. Okay. So what are some nursing considerations that we need to think about with these patients? Well, first of all, you need to be aware that they may have urinary elimination impairment, because remember, this prostate is enlarged and then it causes pressure on the urinary tract, and then it pushes the urine back up into the bladder and doesn't allow it to be excreted through the urethra, and it causes bladder distension. They may also be at a risk for infection related to any type of invasive procedures that they may have had, whether it be a biopsy, a cysto, whatever. So we need to be mindful about that. Anytime we enter a body's sterile tract, there's a possibility that we can take bacteria with us. So we need to be mindful about that. They may need to be put on the antibiotics for a while after the procedure. What type of nutritional intake are they having? They may have nausea and weight loss if their prostate cancer has progressed to a more advanced stage. What kind of pain are they having? Remember, we talked about the tissue being irritated and burned from the radiation therapy. They may have that. They may have some scrotal swelling from some of the procedures that they've had done, or from the prostate cancer itself, if it has metastasized and has gone outside of the prostate gland. They may have some scrotal swelling and edema from that. They also may have disturbed body image, because that can be a very big concern to a lot of patients. Some of the psychosocial effects of prostate cancer are very similar to a lot of the other cancers. We have the anticipatory grief, death. They may be concerned about dying from it. Even though it may take 10 years, they may still be very concerned about dying from the prostate cancer if they don't have any other major issues that are increasing their mortality. So that's something that we need to be aware of. They may be body image, like we said before, that may be a big problem for them. What about lifestyle changes? You know, if they're on radiation or they're on chemotherapy, they may not feel like being as active as they were before, or it may, those therapies may take a toll on their energy level, and they may not feel like going out to play softball or pickleball or whatever they were doing before. It might just really take a lot out of them. Role and relationship changes is also something that we have to think about with these patients, because they're, again, like a lot of other conditions, they may have been taking care of a sick parent or a sick child, or they may be the primary breadwinner. All of those things come into play whenever we're looking at potential psychosocial effects of prostate cancer. What is it going to do to their relationship? Are they married? Have they been married for 30 years, 40 years, or did they just get married in the last 2 or 3 years? What type of effect is that going to have on that relationship? They may have a fear of dying or a fear of losing their libido. How is it going to affect them? Because a lot of that we don't know. It's very individual. We can tell them what our research shows, but it doesn't necessarily mean that that's the way that they're going to be affected. And they may be scared. They're scared of the diagnosis. They're scared of the therapy. They're just afraid overall of losing control and not being able to be in control like they have been in the past. They may feel very hopeless, like it doesn't matter. Nothing that I need or nothing that I can do is going to help me at this point. So those are all things that we need to consider whenever we're working with these patients. We also, if they go home with a catheter, we need to make sure that we have educated them very well on how to care for that catheter at home. What to do if it stops flowing. How long will they have to have the catheter in? What signs and symptoms of infection do they need to make sure that they report to their physician right away? And of course, we want to encourage them to avoid any straining or heavy lifting, especially if they've had a surgical procedure in that area, because the suture lines may be a little bit weaker for a while until the muscle gains its strength. We want to avoid any type of vigorous exercise. And it's okay for them to take a shower unless they've had an open procedure and they have an abdominal dressing on. Their surgeon may want them to avoid a shower and just gradually increase their activity so that they can get back to what's going to be normal for them as far as their quality of life. Does anybody have any questions?
No, I think we're okay.
All right, we'll move on to kidney stones. Okay. Can everybody see the screen?
Yes.
Okay, perfect. Okay, so now we're going to talk about kidney stones. I've included your objectives that's for you to read. I'm not going to read it to you. Some of the terms I've posted here for you is some of the terms that you may encounter in some of your reading and some of the terms that we may use as we go through this material. Urolithiasis is the presence of stones in the urinary tract. Nephrolithiasis is formation of stones in the kidneys. Ureteral lithiasis, formation of stones in the ureter. Hydroureter, enlargement of the ureter. Hematuria, of course, is blood in the urine. Hydronephrosis is enlargement of the kidney due to blockage. And if you think about those terms, uro, well, that means urinary tract, right? Nephro, that means kidney. So if you think about the beginning of those words, it should make it very easy for you to be able to decipher what those terms mean. Okay, let's talk a little bit about some of the risk factors that are associated with stone formation. Basically, the etiology is unknown. We don't know necessarily what causes kidney stones in some cases. About 90% of the patients have a metabolic risk factors, and it may be a diet that may be high in calcium. However, if there is not another a metabolic factor present, typically the calcium doesn't play the high calcium diet doesn't play a factor. There has to be some other type of a process going on that makes the high calcium a factor. And in fact, some diets that are low in animal protein and sodium may actually help prevent stones. And if you think about some of the patients, think about your quadriplegics, your paraplegics. They're very prone to urinary tract infections because they don't empty their bladders completely, and they are down and not moving as much as you and I, who are pretty normal and healthy, are for the most part. Dehydration, if your patient is dehydrated for an extended period of time, that makes them more predisposed to develop stones. If they're obese and white, Caucasian, they tend to be more predisposed to it. If they have diabetes and gout, well, you think about gout, what is that? An accumulation of uric acid in the joints. So that may be the same thing that occurs in the urinary tract. Inflammatory bowel disease, GI problems, urinary tract obstructions may also play an important part in the formation of stones. I'm not really that worried about you remembering the types of stones. I just want you to know that there are different types of stones, and we'll spend a little bit of time on those. But the only way that we really know what kind of stones people have is if we're able either to collect them through a surgical procedure, or if they are able to strain their urine and collect the stones, and then they can be taken to the lab for analysis. That's about the only way that we ever know what kind of stones people actually have. Calcium oxalate, about 80% of the kidney stones contain calcium. And I've put some pictures in here for you too, so you can kind of see what they really look like. They're usually very hard, they're white, and they're usually radiopaque. So we don't necessarily detect those on a regular x-ray. Usually they'll have to have like a spiral CT or something to that effect. But with this particular type of stone, you see it more commonly in people who have had intestinal bypasses or who have an overactive parathyroid gland. It's an autosomal recessive trait that causes the high oxalate production. So things that we want to encourage these patients to avoid is things that we want to minimize their sodium intake. We want to encourage them to stay away from things like spinach and black tea that has a lot of the calcium content. And this is what those stones look like. They can either be round and smooth, which is what you see on the left, or they can have that more of a kind of a staghorn appearance that you see on the right. So if you can even begin to imagine that passing through your urinary system, there's no wonder that these people have renal colic and they have such severe pain with it. Okay, calcium phosphate is another stone. Usually, well, sometimes it can be caused by an inborn error. There again, we don't really know what causes it, but what happens is that the oxalate is a metabolic end product, and it is excreted unchanged in the urine, and that's what attributes to the development of these particular type of stones. We encourage patients to limit their animal protein to like 5 to 7 servings a week. And then we want to limit their sodium and their calcium intake. And there is also some indication that there is an increase in the intestinal calcium absorption as well with this particular type of stone. So that's another reason that their levels may be a bit higher. So, and these are things that we've already talked about. We want to avoid things that are rich in oxalates, such as your beans, your black tea, nuts, oranges, coffee, your dark green veggies. We want to stay away from all of those if we determine that this is truly the kind of stone that they have. These particular type of stones may bring about an infection with them. So if so, we need to make sure we treat the infection. We also need to make sure that we treat any hypercalcemia that they may have as well. So uric acid stones is what we talked about related to the gout. There's about 8% of the renal stones contain uric acid, and they may or may not have gout with it. They may just have uric acid kidney stones. It's usually formed in acidic urine. It's usually very small. It's kind of a yellowish color. It may form staghorn, and typically a regular abdominal x-ray is not going to show it. So you're going to have to do something like the spiral CT, an ultrasound, or some type of a polygram. We don't do a whole lot of polygramms anymore. Now, with this particular type of stone, it is recommended that they limit the amount of organ meat, poultry, fish, gravy, red wine, sardines, things like that have a lot of organ meats in them, because we want to decrease the urine purine as much as possible. And this is proven to be helpful with these particular stones. Okay. And this is a picture of what they look like. You can see how they may be a yellowish color on the left side and then more of a white color on the right side, but you can still see how uneven the surface is and how painful that could potentially be passing through your urinary tract. So we've already talked a little bit about the treatment for that. We want to try to alkalinize the urine as much as we can by dietary changes and increase fluid intake, because we want to flush those stones out of there as much as we possibly can. Now, struvite, about 10% of all of the stones that we analyze contain magnesium, ammonium phosphate, and ammonium and phosphate. These are associated with chronic urinary tract infections. So if your patient has chronic urinary tract infections, this is most likely the kind of stone that they're going to have. And basically what happens, the urine becomes very alkaline and causes the stone formation. So whenever we're looking at dietary concerns for these particular patients, we want to encourage things such as dairy products, organ meats, and whole grains, because these will help to reduce the phosphate and may actually help reduce the stone formation as well. So infection is the main thing to remember with this particular type of stone. And here's a picture of it. You see how all those little horns on it is such a staghorn pattern, and how painful that could potentially be trying to pass through your urinary tract. So we've already talked a little bit about limiting the high phosphate foods and trying to minimize the reduction in the phosphate as much as possible. Cystine stones, these are very rare. We typically don't see these very often. It's caused by an autosomal recessive deficit of the amino acids. So when we see a patient that has a stone like this, it usually forms in acidic urine. It can be soluble in alkaline urine. You may or may not be able to see it on a regular x-ray. We encourage these patients to limit the amount of animal protein that they take in. We want to encourage a lot of fluid intake. However, we have to be mindful about what other conditions the patient has. If they have end-stage renal disease or if they have congestive heart failure, then pushing fluids on them may not be the optimal thing to do. So we have to take all of that into consideration. And the penicillamine is a medication that is used for patients with this particular type of stone, and it binds to the cysteine, which is what causes the uric crystal or the cysteine crystals, and it makes it more soluble. So therefore, it's easier to eliminate it. So it just decreases the formation of the crystals. Here's a cysteine stone. You see how rough and ragged it looks and how painful that is. That could be passing through the urinary tract. Okay, we've already talked a little bit about your dietary interventions, and just be very mindful about what other comorbidities your patient has, because it may not be optimal for them to take in 500 milliliters every 4 hours and 750 at night, because if they're prone to failure, then we may push them over the edge. And also another thing to think about is safety. How old is this person? Are they going to be able to get up to go to the bathroom every hour or two during the night safely? If they're in the hospital, they need to make sure that they call for help before they try to get up and go to the bathroom by themselves. So those are all things that we need to think about with that particular type of treatment. So we've already talked about how we assess the stones. We just have to collect one and get an analysis of it to see what it's made out of, and then advise the patient according to what we find whenever the analysis is completed. Okay, if you have a stone that you may not be able to analyze, then we need to look at other factors. We need to look at there's calcium, uric acid analysis. What does their urine look like? Does it have a lot of calcium in it, or oxalates or cysteine levels? What are those? What type of pH does the urine have? If it's greater than 8, then, they may have a urinary tract infection. And remember, about 6 is where we like to see the urinary pH. And then, of course, we can do the urinary imaging as far as the ultrasound or spiral CT scans to determine if their stones are present. And a lot of times, if they do have stones present, we don't do anything about them. If they're not bothering the patient, we leave them alone. We just leave them alone unless the patient presents with problems. So let's talk a little bit about how we're going to assess our patient. We're going to look at the pain is usually going to be sudden, and it's going to be unbearable. This is what we call renal colic. Now, you will have a very few percentage of patients that don't have the renal colic, but those are very rare. But most patients do. The pain extends from their flank, the flank side of their back, down into their abdomen. And whenever the stone moves, they have increased pain. They may have bladder distension and oliguria if the stone is obstructing the urinary tract infection, and this is considered a medical emergency because we don't want to damage our kidneys' function. So we want to preserve as much kidney function as possible. So you want to assess your bladder for distension. Is it distended? Ask them about their urine output. What color has it been? How long has it been since you voided? Has the smell of it changed? Has anything changed about the quality of your urine over the last day or two, or maybe once you started experiencing these symptoms? Now, with the renal colic, the pain, like I said, is unbearable, and they will be writhing on the bed or in the floor with pain. They're going to have nausea and vomiting. They're going to be very pale. They're going to be very diaphoretic. So we want to make sure that we intervene and provide them some pain medication as soon as possible. Now, there are some tests that we can use that uses a contrast dye. The problem with this is that if the patient already has some renal issues going on, we can increase the chances of acute kidney injury, especially if they're already at a high-risk patient. Let's say that it's a diabetic that maybe already has a little bit of renal disease going on, and then you give them the contrast dye, then you're increasing their chances of acute kidney injury, which can move them along a lot quicker toward their kidney failure. Ultrasounds are really good to diagnose such things as hydronephrosis. Typically, we're going to treat that with NSAIDs and opioids. So it just depends on what's going on with it. And typically with kidney stones, antispasmodics are not going to be very effective in the long run. So one of the medications that we use most often is thiazide diuretics. And basically what we're wanting to do is to increase the urine output. And that's what we're doing with the diuretics. Allopurinol is another drug that's used. And if there's higher levels of calcium in the urine, the thiazide diuretics may also be helpful because they do promote the calcium reabsorption from the tubules back into the body. And it also helps to decrease the urine calcium loads. It's also going to help, like I said, with increasing the urinary volume. We're going to be able to get the patient to excrete more urine and in hopes of getting rid of the stone. It's also going to help pull that urine pH down and hopefully help with the excretion of the stones. And the allopurinol works along the same lines. We've already talked about the high fluid intake as well. The orthophosphates also is another medication that we use sometimes, which alters the calcium phosphorus metabolism, and which what happens with that particular group of medications, it decreases the urine saturation of the calcium oxalate. And then the sodium cellulose phosphate is decreased there is a decrease in the intestinal absorption of the calcium as well. So that's when that one may be beneficial. Now the citrate or potassium citrates, usually we use the 50%, and is used as an alkalining agent. So it's going to change the pH of our urine. It's going to help dissolve any uric acid stones. But we can't use that until we know for sure what kind of stone we have. So it can usually be used to prevent and treat the reoccurrence of stones once we know that that's what kind of stone the patients have. And if the stone hasn't passed in 1 to 2 months, typically it's not going to. Alpha and adrenergic blockers and calcium channel blockers may also be helpful because they help dilate the smooth muscle or relax the smooth muscles. So it helps the stone pass through the urinary tract much easier, and it helps the norepinephrine from tightening the muscles and decreasing the blood flow as well. Bladder analgesics may be very helpful because they're going to help with the pain inside the bladder. The patient may complain of some GI disturbances with that. And we also need to make sure that we tell them that it may stain the urine. Well, it will definitely color the urine, and it may stain their toilet bowl, and it will also stain any clothes that they wear that they get on it. Now, if the doctor chooses to use antispasmodics, of course, they inhibit the nerve stimulation in the bladder. And what happens with these particular patients is that they think about the antispasmodics, well, they become very sensitive to sunlight. So their pupils may appear dilated. So you want to encourage them to wear sunglasses, because the sun may be a bit uncomfortable to their eyes because the antispasmodics has dilated their pupils. So NSAIDs can be used, but we have to be very careful with those because of our renal impairment that can occur, as well as their increased risk for bleeding. And if these patients have to have surgery, then having had the NSAIDs is going to postpone that, because we have to get their system cleared of that before they can go to surgery most of the time. Okay, so let's talk a little bit about surgical management. So what are some things we can do for these patients? Well, we can put a stent in that helps the urine pass past the stone so that it's not backing up into the kidney and causing the kidney to become enlarged and damaged. We may be able to do a ureteroscope on them, which means that they just go in there and take the stone out through a scope. Lithotripsy may be another possibility of a treatment, and that's just where you have a laser that breaks the stone up, and they may have to use a stent after the laser procedure to pass the fragments. We also want them to go ahead and strain their urine after they have the lithotripsy as well, because we want to collect any specimens that we can so we know what kind of stones they are having. They're going to have a lot of bruising on their flank, and they're going to be very, very sore most of the time. Now, the problem with the lithotripsy is that the cysteine stones are resistant to it, so it's very difficult to break up the cysteine stones with the lithotripsy. We want to make sure that they know to take all of their antibiotics, because they are going to be at a high risk of infection. So we want to make sure that they know to complete all of those antibiotics post-procedure. Percutaneous ureterolithotomy, it just basically means that the stone fragments are removed through the skin. And sometimes these patients will come back with a nephrostomy tube. It may be left in place to prevent the stones and fragments from entering the urinary tract. It's brought out through the skin to the abdominal wall, and then it's connected to a small pouch. So they may do that to keep it from going back into the urinary tract. And then the open ureterolithotomy or nephrolithotomy is where they actually go into the kidney itself. They go through a horseshoe type incision on their flank and go into the kidney to remove any of the stones that the person may not be able to pass. So long story short is that this procedure, this process is something that we can't fix overnight. So it's not going to be like your gallbladder. You go in, you have it taken out, and that's it. Because typically they're going to want to see if these patients can pass these stones. So it takes a while for this process to occur. So what are some nursing concerns that we want to think about with these patients? Well, of course, pain management, because they're going to be in excruciating pain. We want to make sure that we prevent any type of infection that may be occurring, and they may already have an infection. We may want to, of course, we want to encourage them to drink plenty of liquids. We want to prevent any type of an obstruction, if at all possible. Make sure they have adequate nutritional intake. What type of psychosocial effect is this having on them? Are they non-functional? Were they the primary caretaker of their children or their mother or whoever? Or what type of psychosocial issues are they experiencing with this? And then, of course, how can we prevent this from happening again? We want to make sure that they know to report any fevers, chills, any difficulty voiding. Make sure they know to finish all of their prescriptions and return to activity as soon as possible. And that just depends on the individual patient and if they pass the stone or they don't pass it, or if they have to have surgical intervention. So all of that's variable. Drink at least 3 liters of fluid a day. There again, that's variable depending on the other comorbidities that the patient may have going on. And then make sure that they keep all of their doctor appointments as well. Now, as far as drug therapy, most of the time the antibiotics that they're going to be using is like the gentamicin or the cephalosporins. Those are usually broad spectrum, and they're usually going to be the first line. Typically, they'll be implemented after the culture has been sent off, so that we know what we're dealing with, and we may have to change those. Now, another thing that we want to be sure that we continue to monitor is the renal function. We want to make sure that we continue to monitor the creatinine level, and then we want to monitor their output. How much are they voiding? There is a medication that may actually be implemented that helps stop the bacteria from making ammonia, which slows the growth of the kidney stones, and it helps the antibiotic to work better. It does not increase the acidity of the urine or have a direct impact on the bacterial effect, but it's lithostat. So you may see a patient on that because that does help stop the bacteria from making ammonia, which slows the growth of the kidney stones. So that's kind of where we're headed with all of that. Post-operative care, if your patient ends up having to have surgery, you want to make sure that you monitor them for bleeding, adequate intake, make sure they know how to strain their urine, monitor their INOs. They're probably going to need some help with their ADLs, at least for the first day or two, until they can kind of get back on their feet. There again, some of the things that we talked about is, make sure they finish all of their antibiotics, strain their urine, expect pain and bruising after the lithotripsy. Does anybody have any questions?
As far as testing purposes, do you want us to know the treatment for each individual stone, or just the treatment for kidney stones in general?
Kidney stones in general.
Okay.
Because I think that's going to be the most beneficial to you as far as caring for your patients. And that's kind of what I try to look at. I try to look at what's going to be most beneficial to you, that's going to help you care for your patients, just like the chemotherapy drugs. Well, I couldn't name all of the chemotherapy drugs either, but we can always go look those up as long as we know what the general complications are from them. Do you know what I'm saying?
Yeah.
Okay.
Thank you.
Okay. All right. Any other questions? All right. Well, I guess.
Dr. Buie, you
yes.
said something about a medication or something that caused the urine to change colors. What was that again?
That is one of the anti-spasmodics. Pyridium is one of them.
Okay.
It's the one that you see used the most. And it will stain the toilet orange, and it stains their clothes orange. So we have to be careful and make sure we educate them on that, because then they get real upset when their underwear is stained yellow and they didn't know it. I mean, that seems like a very minor point to us, but it happens. They do get upset about stuff like that sometimes.
Okay, thank you.
Okay, so on Wednesday, we made a lot of progress today. So on Wednesday, we're going to do erectile dysfunction, and then we're going to do BPH, and we're going to do a review. So if you think of any questions between now and Wednesday, jot them down and bring them with you whenever you come to Zoom on Wednesday.
Okay.
All right. You're welcome. Y'all have a great afternoon.